So the clinical manifestations can present with lethargy, irritability, temperature instability, hypothermia or fever, poor feeding, hypoxia or cyanosis, tachycardia, abdominal distension, vomiting may be there, loose stools may be there, jaundice, exaggerated unconjugated or conjugated jaundice. Typically in urinary tract infections, you get conjugated jaundice and tachypnea. In clinical manifestations of sepsis, you may have hypotension, apnea, shock, DIC, hepatosplenomegaly, bulging fontanellar seizures, and respiratory distress. Investigations include full blood count, and leukocytosis or leukopenia may be seen. Anemia due to hemolysis or repeated sampling may be seen. Thrombocytopenia in line-related sepsis as well. Thrombocytopenia is a common feature, and abnormal liver function test with thrombocytopenia goes with the gram-negative sepsis. Immature neutrophil count may be seen. It's not very sensitive or specific for acute infections, though neutropenia or leukopenia are more specific. C-reactive protein is an inflammatory marker produced in the liver, and it rises in any inflammatory reaction. The neonatal period sepsis is the most common cause, but it can rise after vaccination, surgery, extravasation, and other causes. There's a reasonable sensitivity and specificity of around 70%, and combined with other markers, it may guide. And once a CRP is elevated, its drop may indicate or guide you in the duration of treatment. Procalcitonin is also a useful tool, though a little more expensive, and it rises quicker than CRP. So if CRP is normal in a baby with suspected sepsis, the high procalcitonin may guide you in the treatment. The CRP takes a few hours to rise and peaks over 1 to 2 days. The trend can be monitored as an indicator of response to treatment, and some studies use CRP normalizing as indication to duration of antibiotic treatment, as I mentioned earlier. So TNF-alpha procalcitonin also used similar to CRP, but the faster rise and they normalize sooner. However, they are more expensive. Blood glucose, serum electrolytes, renal function, liver function should be done. And blood culture is, of course, the gold standard, and we should make sure the unit has a policy to collect it in a aseptic manner so there is no contamination. And we should also make sure that adequate sample is sent. At least 0.5 to 1 ml blood sample is needed. Urine culture is more important in late onset sepsis. It's also considered in prolonged jaundice, where especially there is failure to thrive or irritability. A bag urine should not be used, and consider suprapubic aspirator catheterization. Clean catch can be used, but it is time consuming. It's not as accurate as suprapubic or catheterized samples. Cranial ultrasound should be done in preterm babies or those with bleeding manifestations, and blood gas monitoring is important. Use the chest X-ray or abdominal X-ray